Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another podcast. Today I'm with Dr. Andrew Jenzer. He's an oral and maxillofacial surgeon practicing in North Carolina. Andrew, thank you so much for joining us yet again on the podcast.
Grant, is a pleasure as always, my friend. Thanks for having me.
Yes, so we got another informational heavy podcast, which I always appreciate our listeners who reach out and tell me they love hearing from you and they love getting a lot of good info while they're commuting, mostly those that are going to residency, but it's all good stuff. So we're going to continue our discussion on hematology.
Yeah. No, I appreciate that. You know, I always wonder how many of these are simply used to put their kids to sleep at night as they listen to some boring topics or something. So yeah, this is part 2 of the 4 to 5 part hematology series. Unfortunately, my brother, Dr. Max Lloyd, can't be here today. And for the several questions I've gotten, yes, we are full brothers. Our parents are still happily married. They just both kept their names and gave us each one of their names. So different last names, but still normal brothers. As always, please verify anything I mention yourself before using it in clinical practice. And the topic of part 2 today is a little bit of discussion. We'll start out on hypercoagulability disorders, talking about venothromboembolisms, and particularly pulmonary embolisms, and then discuss anticoagulation. So a little bit of a chunky episode today. You done anything new recently, Grant? Any travels or life stuff?
Not really. Just a quick story. So I commute a lot for work and I take some equipment with me. And we had a storm in Denver and I got hit in my car and my bumper got ripped off. Anyways, the car was totaled. So I ended up getting a truck, and I've always wanted a big truck. So I got a big truck and I put all these lights on it, like aftermarket, like bumper lights and KC lights, just to feel like a man. I want to put a winch on it and some other stuff to soup it up. And it's not like I'm actually going to go out in the woods and do anything, but just driving. Anyways, last night I'm on the road and my daughter calls me. Sorry, actually, I was asleep and my daughter called me and said, I ran out of gas. And so I get up from bed like at 11 o'clock, go get her. She's stranded in the middle of some highway, give her some gas and follow her to the gas station. And I was like, I don't know why, but I flipped on my bumper lights that like are super bright because I was thinking she has no gas and it was dark and whatever. So we get to the gas station and this cop pulls up right behind me and pulls me over and he's like, "Excuse me, sir, you're using unauthorized high voltage lights. So this is going to be a situation." I'm like, "What?" I'm just trying to help my daughter get to the gas station. It was dark. "Yeah, those are unauthorized. We're going to have to give you a ticket." And I'm like, "Oh, great." So he comes back to my car and he's like, "Excuse me, sir, have you been drinking?" And I'm like, "Drinking? What are you talking about? Like, I do not drink alcohol." And he like shines his flashlight on my backseat. He's like, "Excuse me, what is that?" You have a box of Topo Chicos that is open. And he shines this box on. I am like obsessed with mineral water, and I have a box of Topo Chico mineral water, like sparkling water. I'm like, "Sir, that's mineral water." And he's like, "Interesting. Looks like alcohol to me, son." I'm like, "What is happening right now? You're going to take me down to the precinct in the paddy wagon?" Okay, so we get out the mineral water. He looks at it. "Oh, I've never seen Topo Chico. That's mineral water." And I was like, I didn't even know that was alcohol. I thought it was all mineral water. Anyway,
that was just water.
So sorry about the long story, but that's what I'm dealing with is teenage girls in the middle of the night that don't have gas and cops that are trying to bust me for drinking mineral water.
Well, now I'm curious. Did he give you a ticket or did he let you slide just because it was not in fact alcohol?
Yeah, after that whole debacle with accusing me of being an alcoholic, he said, "You know what? I'm just gonna let you go tonight, son. I'm sorry for the mix-up," and just gave me a warning.
Nice. Oh man.
Do you have any good stories or no?
Not as good as that. It snowed in North Carolina recently, which was disastrous because we have no snow infrastructure. Just in early February, I was at the ACOMS meeting at Big Sky, Montana. My absolute favorite meeting that exists in oral surgery. Love to see you out there on the slopes one day, Grant. Amazing CE and people. Remember,
Yes.
if you're a resident, you can join as well. But it's my favorite organization in surgery. So if you're not a member, check out ACOMS. It's free or extremely cheap for residents and newly graduates. And truly an amazing group.
It's awesome. So cool.
All right. So to kick it off today, critical concept or kind of our, not really any doctor specific vocabulary, but Virchow's triad. And this has maybe been mentioned once or twice, but it describes the three contributing factors to thrombosis. And the three elements are vascular stasis, intravascular or endothelial damage, and a hypercoagulable state. And if you have one or more of those elements, you're at risk for having a blood clot of some kind. And so let's start just some basics about some of the most common hypercoagulable conditions. There are a lot, which we're not going to go into an extreme amount of detail. And I want to start with factor V Leiden deficiency. And what this is it's a genetic mutation where you develop resistance to activated protein C. And what actually happens is the protein factor V changes its shape due to the mutation, so it can't be turned off by factor C. So we are normally making blood clots, but the normal inhibition pathway can't turn it off. It's the most common congenital hypercoagulability disorder, mostly common in Caucasian and European demographics, and exhibits an autosomal inheritance pattern with some different variable penetrances of heterozygosity or homozygosity. And most of these things I'm just going to mention briefly are, if you are diagnosed with them, they require lifelong anticoagulation, pretty high risk conditions. Kind of next up in that vein is antithrombin deficiency. And we'll be talking more about antithrombin as we start to talk about heparin because that's how it works. But the older term is antithrombin 3. And these terms are used synonymously. So you can kind of colloquially use antithrombin or antithrombin 3, although currently antithrombin is the correct term. And antithrombin is a key factor in kind of the normal biofeedback mechanism for turning off the coagulation cascade. When somebody is given heparin, it actually upregulates this enzyme by about 1,000. To really shut down the coagulation cascade, making us very bleedy, right? That's the point of heparin. So when you have the mutation there, the patient develops a hypercoagulable state. And there's a couple different types, a quantitative and a qualitative deficiency. The interesting thing is this can be acquired after, say, trauma, surgery, disseminated intravascular coagulopathy or liver disease. So it's kind of interesting that some of these bad states can actually be acquired after an event. And then we can have protein C and S deficiency. Remember, those are made in the liver. They're part of the normal pathway that kind of breaks down blood clots. And you can have qualitative or quantitative defects of one or both of those. Again, kind of another autosomal dominant pattern, and they can be acquired as well from all sorts of things. And other things to mention about reasons why somebody might need anticoagulation: atrial fibrillation, which I know we've discussed in the past in cardiology, extremely common, right? At least 10% of people over the age of 65. The reason that people need strong consideration for anticoagulation in AFib is the irregular nature of the heartbeat creates pockets of stasis within the atria. Those blood clots can form and then propagate. Prosthetic cardiac valves. There's a whole family called the JAK-2 mutations that manifest with all sorts of weird stuff and hepatobiliary things, as well as coagulation issues. And antiphospholipid syndrome, something that can commonly happen in people with systemic lupus erythematosus or lupus. And all these things can manifest with VTEs, or venous thromboembolisms, another way of saying blood clot. So you'll see that abbreviation a lot in literature, VTE. But I do want to talk about pulmonary embolisms briefly. And this is a mechanical obstruction of one or more vessels in the pulmonary vasculature. We have a couple ways of describing it and thinking about it. We can call them acute or chronic, depending on where they propagate in time, partial or complete, large or small caliber vessels, And the two particular terms that have implications in their symptoms, massive or submassive. Massive, when you're describing a pulmonary embolism, means that you have systemic symptoms, typically hypotension or a shock picture with hemodynamic instability. Whereas submassive means the blockage affects kind of the right heart because you get kind of back up into it, and you might have some strain, but without systemic big manifestations that are kind of life-threatening, like that hemodynamic instability. And really what that means is that somebody is displaying those things and they have a massive PE, they may require more aggressive treatment in order to kind of fix things. And even though we think of these usually being blood clots, a thromboembolism, they actually can be other things. They can be septic emboli, air embolisms, emboli from tumors, or fat emboli. We always think about femur fractures can release fat into the bloodstream in particular, and those chunks of fat in the bloodstream can cause all the same bad things that blood clots can. What do you think, Grant? Any questions so far, or we're getting some memories of hypercoagulable conditions?
Yeah, for sure. That's really helpful, especially breaking down the PEs. It's just a common thing we see
Yeah.
a lot in our patients and their history.
And if we think a little bit about the pathophysiology, what's actually going on with those PEs, well, we get that vascular occlusion somewhere, resulting in hypoxemia, a decrease of oxygen in the blood in particular. And that leads to pulmonary vasoconstriction. That increased pulmonary vascular resistance and pulmonary artery pressure decrease the right ventricular stroke volume. Our heart tries to compensate and becomes tachycardic. And then if it gets worse, it can build up into increasing the afterload of the right ventricle. This can increase the myocardial oxygen demand. And then if their heart's not that healthy or strong, then we can start to have ischemia, leading into infarction and dilation. And all these things can just progress into circulatory failure. And obviously there's the degree of the occlusion dictates the degree of the consequences. These patients may present with dyspnea, tachypnea, pleuritic chest pain, hemoptysis, coughing up blood, fever, cough, kind of, generalized chest pain, feeling bad, changes in breath sounds. When I talk to residents and, I try to beat into their minds this floor differential. You have a patient in the hospital and something is just not right? They might be tachycardic, they're unwell. You're going to see them. Some of those acute things that you really need to think about ruling out are things like MI, a pulmonary embolism, a stroke, some of these acute conditions that, might need intervention really quickly, calling for help kind of thing. But PE is definitely up there. And, look at their legs, evaluate it. The most common source is the, deep vein thrombosis from the lower extremities, but they'll often be red and swollen. A little bit of historic, but I remember used to getting pimped on this. There's some signs and symptoms like Homan sign, right? Dorsiflexion of the foot, raising it up, causing calf pain. But that's less than 50% sensitive specific. So a little bit historic context. And so if you have a stable patient with a suspected PE, there are a few different criteria. I'm not going to go through them, but you should look at the Wells criteria. That's kind of my favorite. Depending on their score, it indicates either a low, intermediate, or high risk of PE. That intermediate category is where, you could consider a D-dimer test. I know we talked about that in the last episode and how that's not really good for any of our surgery patients. But if they have a high clinical probability, you want to get a CT angiography of the chest, also called a spiral CT, to kind of look for that so you can see it. And don't forget, if you actually have some findings clinically in the lower extremities, it's a good idea to get an ultrasound if you can get it kind of quickly. You can often see those clots in the lower extremities. And the management of pulmonary embolisms, well, they need to be anticoagulated, but the timing, the length, the type, it's dictated, and this is going to be a critical set of guidelines for this podcast today is the CHEST guidelines. And the CHEST Society is the American College of Chest Physicians. They put out a number of different guidelines, including, it's less in our world, obviously, but the answers to what you do for this. It's going to be a recurrent theme because one of the best documents I can encourage you to look at is the 2022 CHEST guidelines on the perioperative management of patients on anticoagulation. So we'll talk about that a little bit later, but this is going to be a recurring theme today as one of the best sources of evidence for us, for perioperatively, how we deal with these folks. You want to start these patients who have PEs on anticoagulation. It does not fix the blood clot, although it prevents propagation or more blood clots from happening. So I see a lot of folks get tripped up on that. It actually doesn't fix the blood clot. It prevents it from getting worse and from other blood clots happening. You want to consult medicine, CT surgery, get some input, but generally, some of the treatments can be fibrinolytics, especially for massive PEs or submassive with evidence of systemic problems like impending respiratory or circulatory collapse. Examples of those, and there's many of them, include things like streptokinase or alteplase. You can consider an embolectomy, and this can be done endovascularly or open if severe and indicated. Getting in there and surgically removing the actual emboli. If anticoagulation is contraindicated, then we can actually try a couple other things. A filter can be put into the inferior vena cava to kind of capture the clots and prevent them from going back into the heart and circulation. And that's typically called a greenfield filter. But there's other types of filters that can be put in places. For example, a Watchman's device is a similar kind of filter placed into the left atrium. And most of patients who do get a pulmonary embolism get anticoagulated for at least 3 months. A lot of, obviously this is kind of their world, but understanding the hematologist's view a little bit, they try to figure out if it was provoked or unprovoked. Provoked might mean they laid in bed for a week or have some sort of reason why they'd be at a higher likelihood for it, versus if they have it completely randomly and unprovoked, then that might be a little more worrisome. Most of these patients are going to get kind of a full workup to look for some of these hypercoagulable conditions. But depending on their symptomatology and the nature of it, that might lead to a longer course of anticoagulation, maybe a lifelong, or sometimes just a 3-month course with close follow-up. What do you think, Grant? Questions, anything to review or touch on within that?
Can you explain again just the difference between provoked and unprovoked?
Yeah, provoked means that something happened that would put them at a higher likelihood. And, a lot of times, if you think about all the stuff that we do to help prevent PEs, which might be good to talk about, patients in the hospital for long periods of time are bedbound and not moving. An older person on an airplane who's not wearing compression socks and, sits for 8 hours on a flight without moving around, allowing a chance for the blood to kind of pool that element of Virchow's triad, that might be considered a provoked, as opposed to unprovoked, meaning none of those factors that might increase their risk contributed to it. In terms of, things that we can do in our patients, this is the reason why we use SCDs or sequential compression devices, the little leg squeezers. You may think that they work by squeezing the blood and helping it to move, but that's actually not true. The SCDs increase the concentration of cyclic GMP, which leads to increasing nitric oxide, causing vasodilation. If you use one SCD, that's still okay. So even if they're restricted on one side, you still want to use one if possible. The best thing you can do is get your patients up and walk. I am really big on getting my patients out of bed and having them walk for a myriad of reasons, but preventing blood clots is one of them. Obviously, in some folks, that's easier than others, depending on their health. Or we can use chemoprophylaxis, right? Small doses of usually subcutaneous heparin or other things. What I've noticed, I think, in oral surgery, we tend to use that a little bit less, especially on healthier patients. And I tend to lean more on walking and SCDs and really only reach for that chemoprophylaxis if I have to.
That's great information.
Awesome. So that brings us right into anticoagulation. And these are various medications that are used to prevent or treat clots, thromboembolism, or thromboses. And some of the major categories that we'll talk through include heparins, warfarin, and direct oral anticoagulants, as well as DAPT or dual antiplatelet therapy, we're going to just mention, even though it kind of fits more in cardiology. And so again, the CHEST guidelines, check it out. The 2022 paper on perioperative management. It's a great single source of a lot of the evidence. We'll kind of talk through each of these categories of medication and then what the evidence. I have recently done a major literature review myself on these topics to try to get and understand the most current guidance. So we'll talk about the perioperative management and the evidence for that for each type of medicine. And I want to start off with the heparin-based medications. Remember, we measure heparin with a PTT or a partial thromboplastin time. And what does it do? It increases antithrombin or antithrombin 3, which is a serine protease inhibitor. This shuts down the clotting cascade in many places. It affects factor 12, 11, 10, 9, 7, 2. So a lot of different places it hits. And heparin kind of allosterically binds to it and upregulates it by at least 1,000-fold. So it really cranks up the body's ability to shut down the clotting cascade. Makes sense, right? Makes us bleedy. Probably the most familiar way, if you've seen this used in a hospital, is a heparin drip. This is typically done in an ICU setting, but this is what we call unfractionated heparin, meaning it's of various sizes. And it's pretty interesting as we talk about these, the sizes really dictate how these molecules work. So this is actually porcine derived from pigs. And unfractionated heparin is a range of sizes from 5 to 40 kilodaltons. The actual numbers don't matter, but just understanding the variety in size will help you understand the different mechanisms of action here. And the big mix of sizes actually explain the unpredictability and constant need for titration. If you haven't, or if you have seen a patient on a heparin drip, usually they get constantly titrated. They get labs every hour or two. The drip goes up and down. Really bad things can happen. And I have seen patients, really significantly injured due to mismanagement of these things. Hence why they're usually in an ICU setting. Because the various sized molecules can kind of randomly bind to almost all places in the coagulation cascade. So just depending on the size, not only that antithrombin mechanism, this is why it's so unpredictable. So what did they do? They didn't, what's a different way we can use this medicine so it's not so hard to use and unpredictable? Well, they actually chopped out all the big stuff and refined it so that our next category is low molecular weight heparin. These are technically molecules that are 8 kilodaltons or less, typically 4 to 5,000. But this focuses the mechanism of action and makes it predictable. How that actually works is the much smaller molecules more focusedly bind to antithrombin and not those other things, and actually increase the mechanism by 2 to 4,000-fold. The focusing the action really stimulates it to hit mostly factor 10, 10A in truth, making it very predictable. So these are drugs like enoxaparin or Lovenox. Generally, a good thing to remember is 1 milligram per kilogram BID as a full anticoagulation dose. And if you want to measure somebody's bleeding on low molecular weight heparin, the lab that you need to get is an anti-factor 10 assay, not the PTT. So a little bit different, but very predictable. We don't need to keep them on a drip. These are the common medication when we talk about bridging. Great medicine. We have one final category called synthetic heparinoids. Remember, if something ends in oid, O-I-D-S, it means like or similar to, lichenoid mucositis, for example. A lot of oral pathings have that. And these are very tiny, small molecules, generally 2,000 kilodaltons or less. And these are things like fondaparinux or bivalirudin. These are actually safe in patients with HIT, heparin-induced thrombocytopenia, kind of bad autoimmune sequelae that can develop from heparin. But they're pretty rarely used and often used in patients who are actively on ECMO or kind of a different cardiac bridges in order, kind of on the way to cardiac transplant. So very sick patients who are, between therapies as they're in their course of treatment. So not super common, but safe in patients with HIT. Unfractionated heparin, kind of moving back to thinking about the heparin drip, has a very fast onset. It's used a lot intraoperatively in vascular surgery. For those of you who have ever done anesthesia for vascular surgery, they'll be on heparin. You have to reverse it, and we reverse it with protamine sulfate, and that is actually made from salmon sperm. So you have to be very careful with fish allergies. People actually, the more they're exposed to protamine sulfate, can develop allergies to it because of that high allergy characteristic and profile. I have had a vascular patient have a full anaphylactic reaction under anesthesia because of this constant heparin, then protamine sulfate, then heparin. So that was very bad. He survived, but it was not a good situation. If we want to talk about reversing low molecular weight heparin, protamine sulfate can give you about a 60% reversal, but we don't have a good way to kind of fully reverse that. And a mnemonic that I like, just to touch on it again, is heparin leaves the baby happy versus warfarin declares war on the baby. So heparin and heparin-based drugs are, generally, with some exceptions, good for pregnant patients. What do you think, Grant? Any heparin thoughts?
Yeah, that's really helpful that you broke it down from and talked about the sizes and what it means when it's unfractionated and all that stuff is helpful. One question is, how if people are on warfarin, we can check their INR, and there's like little office portable devices. It's super quick and easy. Is there something the equivalent like that, like a anti-factor 10 assay device that you can check it quickly in the office, or no?
That would be awesome, but no, that's definitely a hospital only thing.
Okay, that's what I
The
figured.
thing is, like, it's very rare that you'd actually have to check an anti-factor 10 outside of like an emergent setting. And if somebody is on Lovenox or low molecular weight heparin and you're moving into the surgical phase, it will be, depending on the management of it, they may just be like, okay, you're going to stop taking it 2 days before, a day before, or something. So you would not have to check a perioperative lab unless you're like dealing with a trauma and you're kind of rushing to surgery. And then, you'd probably be dumping a number of products in them to try to reverse it as much as you can. Or, most of the time in our world, just, try to wait it out a little bit, get a day or two down the road, and then do the surgery. You're right, though. That is maybe in the future, which brings us to kind of the next thing, the other major category, warfarin. Remember, warfarin is also called a VKA, or a vitamin K antagonist. So a lot of times in the literature, it'll just say VKA, and what they mean is warfarin. It's measured with a PT, a prothrombin time, right? WEPT, warfarin affects the extrinsic pathway and is measured by a PT, that helpful mnemonic. Remember, we have factors 2, 7, 9, 10, and protein CNS are our vitamin K dependent factors made in the liver. Although all factors are made in the liver except for factor 8 and von Willebrands, which are made in the endothelial cells. How does warfarin work? Well, we take it, it's absorbed by our GI tract, and then there undergoes some transformations. And one of the ways that vitamin K is a series of enzymatic reactions, but there's an enzyme called vitamin K epoxide reductase. And warfarin blocks vitamin K epoxide reductase. So the active form of vitamin K cannot be made. Therefore, those vitamin K dependent factors, 2, 7, 9, 10, and protein C and S get turned off. And when I do want to talk here about bridging, and what is that? It means bridging is going from warfarin to a more heparin-based anticoagulation for surgery in order to kind of better control the bleeding if we have to, and then switching back. Because warfarin is harder and more unpredictable to reverse as opposed to some of the heparin products, which tend to be more titratable and controlled. Bridging is rarely recommended for patients with a high risk of thromboembolism. And we're going to spend a little bit of time talking about risk because it's kind of the crux of the discussion. But for example, a mechanical heart valve, depending on the type, there are various risk score assessments like the CHADS-2 VAS score. And I'll leave it there. We'll talk more about risk in a while. But how is it done? So bridging is really managed by, obviously, the anticoagulation team, and generally involves something like the following. About 5 days before surgery, they would stop warfarin. They would start a low molecular weight heparin, maybe like Lovenox, about 3 days out. They would stop the Lovenox a day before surgery, and then restart one or both after surgery, depending on the thromboembolical risk. One of the most variable phases of this entire thing is actually the backside of it. It can be quite variable depending on patient-specific risk factors. The front side, usually looks like I described, plus minus a little bit of time, but the when to restart stuff afterward is quite variable. But there's something critical to understand here, and that's what happens when we first start taking warfarin or when you restart warfarin after bridging. And there's a really bad thing that can happen, and that's warfarin-induced skin necrosis and some other similar complications. Because when we start taking warfarin, it turns off factors 2, 7, 9, 10, and protein C and S. The half-lives of those are actually pretty important. The half-lives of factors 2, 7, 9, and 10 are about 36 to 72 hours, whereas the half-lives of protein C and S are 6 and 8 hours respectively. What that means is a patient actually becomes hypercoagulable for about 3 days, even up to 10, when they start taking warfarin. And if that happens and they're not on another anticoagulation medication, then little microclots can start forming. Those get to your skin, can block your capillaries, and you can get this horrible complication called warfarin-induced skin necrosis. You Google it if you haven't heard of it, but I think huge black splotches in the body. They look like awful burns. obviously strokes, PEs. So when people start warfarin, they usually have to be started along with something like a heparin-based medication like Lovenox to help cover for that initial hypercoagulable phase. Does that kind of make sense, Grant? That's like a critical thing that I usually see misunderstood when we're trying to understand bridging and the reasons behind it.
Yeah, that's super helpful to talk about that process of how it makes you hypercoagulable and sometimes the need for Lovenox.
Awesome. How do we reverse warfarin? Well, we can use vitamin K. We can give that IV or in other forms. We can use something called PCC, and that stands for prothrombin complex concentrate. This is commonly called K-Centra. And the way we describe PCCs is we often call it 3-factor or 4-factor PCC because it has factors 2, 9, 10, and then sometimes 7, depending on the brand. So that'll be the difference between a 3-factor and a 4-factor. So we're essentially giving back the exact products that warfarin turns off. Great, right? Vitamin K, if you give it, takes about 6 to 12 hours to work, so a little bit slower, especially if you're thinking about an urgent situation. We can also use fresh frozen plasma, right? Just give somebody back their volume plasma that has all the factors in it. PCCs are particularly helpful over some of these other things because they have a much smaller volume and a much higher concentration of factors compared to, say, FFP. So it really reduces the risk of volume overload and has a much faster reversal. You get about a full reversal with PCCs in about 30 minutes, depending on the brand and product. And it doesn't need to be thawed out, right? FFP takes about 20, 30 minutes just to thaw before you even give it to somebody. So PCCs are a pretty helpful reversal thing. And understanding what's in some of these reversal products too, you can play kind of mix and match or understand, hey, if the patient's missing this factor, all right, PCC has, 2, 7, 9, 10, I can give them this for this, at least transient. And I think this naturally transitions to kind of the last major category here, the DOACs. And the acronym DOAC, DOAC, stands for direct oral anticoagulant. And this is a group of medications composed of a single direct thrombin inhibitor, and the rest of them are inhibitors of factor 10A. They kind of used to be called NOACs for new or novel oral anticoagulants. So you'll see that in the literature, but they're not novel anymore, so we just call them DOACs. So initially, the only direct thrombin inhibitor that I'm aware of, maybe there's others or very recent ones, is called dabigatran. The trade name is Pradaxa. And it works by binding directly to thrombin, preventing it from catalyzing fibrinogen into fibrin. So we stop factor 2, don't make the blood clot. The factor 10A inhibitors are some examples: rivaroxaban, which is also called Xarelto, apixaban, which is also called Eliquis, and about 5 or 6 different other ones. What's nice is there's 2 things in the name that tell you it's a factor 10A inhibitor. They all end in ABAN, A-B-A-N, and they all have the letter X in it to indicate that they stop factor 10, usually XA, actually. So the tricky thing, and part of understanding why DOACs weren't as common and now are becoming more common has to do with reversal. So with PCCs, like we talked about, we can use for warfarin, we can get a partial reversal for DOACs. So PCCs, prothrombin complex concentrates, are pretty universally helpful to some degree. But in 2018, a full reversal agent was approved for factor 10A inhibitors. And this is called andexanet alpha. Just typically called Andexa. It's a recombinant modified version of factor 10A. It was approved for reversal of just rivaroxaban and apixaban, but it can be used for any of them, and it kind of acts like a decoy molecule. What's interesting is it's extremely expensive. Usually an adult patient would need about 6 vials of this medication for a full reversal, and the cost of that is, on average, as a rough statement, around $75,000. So extremely expensive. Emergent life-saving only. Every time I go to a new hospital, some of the medications that I ask pharmacy to understand if they stock, one of them is Andexa, another being icatibant, a helpful reversal agent for C1 esterase deficiency when thinking about angioedema, because I've had to deal with that. It's a good idea for you to know if your local hospital, if you take call, stocks this. Backing up to dabigatran or Pradaxa, it has a specific reversal agent, a monoclonal antibody that you can give that turns it off called Praxbind. So that's nice because it has its own reversal agent. And this development of this reversal agent was super critical in understanding why warfarin is now being phased out. Because the DOACs have a huge advantage. You just take a pill once or twice a day. There's no labs involved. And they have relatively short half-lives, usually 8 to 14 hours. Whereas warfarin is an awful drug, right? It's literally rat poison. They have to go to the warfarin clinic usually 5 days a week to get their INRs checked. They're covered with bruising. Their dosing is extremely variable. It's a really awful restriction on life most of the time. So why do we use it at all? Well, it used to be that the DOACs, without a strong reversal agent, if somebody were to fall and have a brain bleed, be in an accident or something, that would be it. You couldn't really fix it or turn it off. So thinking about the has bled score, somebody's risk, for example, of having some type of major bleed, that person used to be put on warfarin more so. But these days, a lot of the first line therapies are starting to become DOACs. For example, right now, the first line for non-valvular atrial fibrillation for anticoagulation is a DOAC. And I think we're going to see warfarin being phased out more and more and more. And DOACs, as the evidence accumulates, probably over the next 10 years, become first line for a lot of different things. But those studies still have to be done. But we're starting to see it over the last 3 to 4 years. They're becoming a lot more common. And lastly, the last little category just to mention here, dual antiplatelet therapy. And because we're going to talk about a little bit management perioperatively. So why are patients placed on this? Usually it is aspirin and a P2Y12 receptor blocker, commonly Plavix or clopidogrel. Most commonly, this is to decrease coronary artery thrombosis because after they have a stent placed, those stents are thrombogenic, right? Remember, these days, typically drug-eluting stents are placed. The antiplatelet regimen prevents, clots, particularly for thrombosis for reforming, where the drugs in the stent prevent neointimal hyperplasia and slow the rate of epithelialization. And remember, they're often on it for 18 months, but are now being continued on one or more of those in very patient-specific ways. Or, sometimes as a situation where they couldn't necessarily tolerate full anticoagulation, this might be an off-label use for kind of like a medium anticoagulation. But this is going to get sticky when we talk just briefly about what if they're on both of these, and that's a difficult area. Before we move into now perioperative considerations, Grant, any touch base points, thing to clarify or go back on in that?
It's helpful to review the DOACs and the antiplatelet drugs. I mean, we see so many patients now on Plavix, Xarelto, Eliquis. I mean, do you know of any differences or like why someone would be on a Xarelto versus Eliquis or Pradaxa? Or are they pretty much the same and just depends on the provider?
That's a good question. I don't. That would be a good question for us to ask Max in the next episode. We'll make a note and revisit him. From my understanding, they're relatively similar, maybe cost or I think there's a lot of specific studies comparing one versus the other in very particular patient populations. But I think that's I would guess it's a very deep rabbit hole. But from my superficial view, I think it's, 6.5 dozen one the other for the most part.
And so in general, you're saying the DOACs are used for, I guess, system issues that are more likely to cause anticoagulation or coagulation, such as AFib, whereas antiplatelet is more for like a stent or something that is causing local platelet stickiness and clots.
Yes, exactly. The dual antiplatelet therapy is really targeted toward decreasing the thrombogenic kind of formation of a thrombus with the coronary vessels. Yeah. However, if you do that to the platelets, you get kind of that, as we know from folks who have operated on those patients, you get more of a bleedy picture simply because you're not affecting the coagulation cascade, but you are affecting the primary hemostasis. And just to clarify that, I mean, I remember when I was doing medicine things. Seeing a patient who was older and very ill and needed anticoagulation consideration, but would not have survived, could not tolerate it. So after discussions with the family, we placed her on a dual antiplatelet therapy to, kind of balance that. Well, we don't want to have her stroke, but, if we anticoagulate her, she falls literally every hour. Like, she's going to have a brain bleed and die. So what do you do? So I think you can, that's like more of the off label, but understanding when you see these meds, making sure do I understand the reason why they're on these things? And if not, making sure you clarify that in your consult, probably a very good idea. So perioperative management. If you're listening to this, make a note. I want you to Google it, CHEST 2022. And the specific paper is Perioperative Management of Antithrombotic Therapy. Fantastic. It shows you all of evidence, and I'm going to be summarizing that for you as long as the evidence I've looked at. And guess what? There's no magic answer. It's a lot of gray area and uncertainty. It all comes down to risk stratification, individualized patient risk factors, and communication with the hematologist or managing provider. However, I hope to give you some factors to better understand how the hematologist looks at it, and especially how they understand risk, some of the current evidence, so that you can better communicate and make good choices for your patients. And so first, I want to talk about risk, right? Not the board game, but the factors that play into that, so that we can understand how particularly medicine evaluates bleeding risk. What kind of factors affects a patient's risk, their age, their indication for anticoagulation, their renal function, various scoring systems. And when we talk about scoring systems, like, you hear me saying a few of the common atrial fibrillation scoring systems. The CHADS2 VAST score, right? The HAS blood score. These are used to predict the risk of stroke and AFib, right, within 1 year, with the CHADS2 VAST versus bleeding 1 year on the HAS blood score. Particularly, these have been actually, from my perception, limited from the hematology and other providers. They're so well validated that they get used even outside of AFib to look at bleeding risks. So there are others, but you may see some of those in risk stratification for any of this bleeding stuff. So if you're wondering why, that is why. But generally, when we talk about low risk, that's going to mean a severe or major bleeding event about 0 to 2% of the time. High risk, generally 2 to 5% chance, 2 to 4 to 5, something like that. And how do they define kind of this major or severe postoperative or intraoperative bleeding event? Something that could be fatal, require transfusions, or drops the hemoglobin by 2+. So, and you'll kind of see some themes about when we talk about generally these risk profiles are generally going to be in this low category, right? Somewhere between 0 and 5% for the folks that we're talking about doing these procedures on. Here's where it gets murky, right? All these guidelines, and I've looked at them all, you can as well. If you actually find the paper on this, the dental section on up-to-date perioperative management within the CHEST 22 guidelines, they say things like, dental procedures are considered to confer a low risk of bleeding, and anticoagulation can be continued in most of these patients. An exception is multiple tooth extractions, which we consider high risk. So they simply say dental low, multiple teeth high. And this is a large crux of the problem, because when you look through all these things, the language and the qualifiers are extremely murky. What about 4 teeth? What about 7 teeth? What about implants? There's not really stuff that actually classifies it like this. So we'll kind of keep that in mind as we go through this. But in my review of the literature for perioperative management for all these types of medications, there are some recurring themes in all the papers I looked at. I looked at about 70 to 80 papers. Some of the themes involve, for all of them, that most evidence and recommendations are around single tooth extractions. Right? The paper might say something like, we took out 98 teeth in 90 patients. Something like that, where it's like maybe a couple or two, maybe more, but it's not very specific. Most of the studies are about 100 patients or less. There's extremely variable definitions of bleeding, like what constitutes bleeding, variable follow-up, and most studies included a use of hemostatic agents at the time, right? We took out the tooth, we put gel foam in and did these other things. And like I said, it gets murky because multiple teeth, a lot of qualifiers, but a big picture thing is postoperative bleeding or bleeding problems happen about 1 to 5% of the time. And that was kind of across the board for most things I looked at. What do you think so far, Grant, before I dive a little deeper into the rabbit hole?
That's some good stuff. Yeah, I'm glad you are reviewing some of this. It's crazy you read that many papers, but Yeah, you kind of wish there was a little more detail about, what constitutes quote unquote multiple or many teeth and what procedures really are super high risk, that type of stuff.
I do have a little bit of guidance as we get further on. So
Okay.
it will
Okay.
get a little better besides, set the bar low, overachieve, right? Keep your patients happy. That's what I try to do.
Right.
I want to start specifically with warfarin, and particularly perioperative management of warfarin. I looked at about 35 papers for the last 10 years. The best papers that I was able to find were 4 randomized control trials and 1 meta-analysis that were quite large, and they all showed that there is no significant increase in bleeding, except about 1 to 5% of the time, right? We keep hearing that go back to, and that's why I'm trying to point it out. If you're doing this, you can expect bleeding problems up to 5% of the time, generally 1 to 5. But again, out of all these studies, most of them were single teeth extractions and used hemostatic agents, right? All the broad themes I was kind of mentioning. But you have the largest papers kind of doing these large reviews saying it is okay to operate through warfarin. And guess what? A lot of the evidence that does exist says we can operate and maintain the patients on anticoagulation for all the types, if you're willing to accept that 1 to 5% of major issue afterward. And understand that the evidence is not good and mostly on single teeth or smaller studies. Moving on to dual antiplatelet therapy. Similar concerns with the evidence, although the CHEST 22 guidelines cite over 100 randomized control trials looking at this, and the rate of bleeding is a touch lower, 0.5. So, we can shrink our, we have to expect bleeding afterward on those patients, but potentially, again, we can operate through dual antiplatelet therapy. The DOACs are interesting because they're new enough where I found it quite funny. Within the CHEST guidelines, every statement they make about them, there's this giant bolded phrase that says very low certainty of evidence. So understand that the evidence is not good for any of this stuff yet. But generally, no matter what the source you look at, you may see something like if the risk of bleeding in the surgery is low, they might stop the DOAC 24 hours before surgery, restart it the 24 hours after. High risk 2 days before, 2 days after, or something like that. And it's because the half-life of DOACs are about 8 to 14 hours. So after about 48 hours, we're at a fourth of the half-life, about 12.5, and the effects are really not there. Interesting, and just to mention, bridging is not a thing with DOACs. So we can't think about it like warfarin. The evidence is actually against performing any type of bridge. We simply turn it off and then turn it back on after. A major trial that informs a lot of the DOAC recommendations is something called the PAUSE trial from 2019. This is like the one that's cited when you look at any of the recommendations made on up to date, the CHEST guidelines, a lot of things. It took a little over 3,000 patients who were on DOACs who had a mix of surgery, and that was included dental, cardiac, GI, and ophtho. And they stopped the DOAC 1 to 2 days out. They restarted it 1 to 2 days after, and their rates of major bleeding were about 2%. Again, saying, hey, this kind of formed that core of how we manage that. So with DOACs, generally, but there's some European and US guidelines, but for 2 to 3 teeth or less, we can generally continue them safely. That's kind of the major thought. For more than that, you want to, consider stopping or holding it. And again, that feeds into more of that high risk category. Although remember, it's extremely poorly defined. Like, we don't know. And the hard part about this is I think the people on the other side of it have no idea what we do, right? Oh, multiple teeth extractions, they just say high risk, right? But what about 4 teeth? It's tricky. There's one more category. Shout out to my buddy Zach Daniels if you're listening, to bringing this to my attention. These are incredibly sick people. In a category called triple antithrombotic therapy. So patients who are typically on a DOAC and a dual antiplatelet therapy. Something like they have bad AFib with a history of blood clots, so they need, say, a DOAC to help address that. And they recently had a heart attack and stenting and need the dual antiplatelet for that. And this is a really tricky category because obviously they're on more than a full anticoagulation as well as their platelets. I was not able to find really any good perioperative management recommendations for these specific patients. Obviously, they're going to be pretty ill. The duration and timing of what they call this triple therapy is quite variable, but as a broad statement, It should be a short period, like 1 to 3 months, like immediately after the stenting for the MI. But some of the kind of qualifiers that I could find were these patients are at a baseline risk of 2 to 5-fold higher chance of having a major life-threatening bleed, which makes sense because you have them on all these medicines. So if you are thinking about having to do some sort of surgery on a patient in the triple therapy, that's, I would be very careful with that. Probably treat that patient in a hospital or have a long talk with their managing providers because they're going to be more bleedy potentially than somebody who's just fully anticoagulated. So what do you think, Grant? I know it's the not the good answer, the fact that we have no evidence for this stuff and you can kind of do whatever and literature supports it. But
Yeah, I mean, even if we don't have a ton of literature, it's helpful to review this. I mean, we see patients all the time now that are on DOACs,
yeah,
and I think just paying attention, asking them, doing a good history, paying attention to why they're on it, making sure they're not on other, you know, platelet therapy or other things, but being thorough, and it's just super important.
and to answer your previous question, a great paper, which I loved, was in JOMS, our Journal of Oral Maxillofacial Surgery last year. And this is by Jazz Dillon and her group. And the paper is called Perioperative Optimization and Management of the Oral and Maxillofacial Surgery Patient, a narrative review on updates in anticoagulation, hypertension, and diabetes medications. If you haven't checked it out, it's really good. One of my favorite things in the paper is they put a chart in that tried to put oral surgery procedures into risk stratification. So under the low bleeding risk category, they listed dental extractions, 1 to 3 teeth, incision and drainage of intraoral swellings. Under the intermediate bleeding risk, dental extractions more than 3 teeth, implant surgery, ridge bone grafting, soft tissue biopsy. And then under the high risk category, things like oncologic surgery, reconstructive surgery, open facial trauma, orthognathic surgery, large excision of bone or soft tissue. So that might be a good, I think, framework for us to think about things. More than 3 teeth, you're at least in that intermediate category. Multiple implants. Those are all times when, having the conversation with the hematologist would be a really good idea. So check out that paper, 2024 JOMS by Dillon, Dillon, Jazz. So big takeaways from what we just talked about, right? You can, in conjunction with the managing provider, hold or continue anticoagulation based on your ability to deal with and control the bleeding and the patient-specific risk factors. Because there is downside in stopping this as well, right? These patients can have another VTE event. They can have a PE or stroke. I've had friends who have had that happen. If they're on warfarin and staying on it, like you mentioned with some of the slick devices, you really want to get a perioperative INR the day of. If you don't have one of those devices, having your patient go get a blood draw and then coming to you for the surgery, you need to think about what INR you're okay with doing surgery on. Right? Smaller procedures are definitely probably safe up to 2.5. I'm personally pretty cautious over 3, but there are many publications and trials in the last 20 years that advocate that a range of 2.5 to 4 is safe. But again, that's something that you personally need to determine in conjunction with the treating provider. And ultimately, it comes down to our ability as surgeons, right? Grant, like how can we control it in the office we're in with the supplies we have? And what if something bad happens, right? And I think there's a lot of surgeon-specific factors involved as well. And remember, don't use NSAIDs in these patients. It impairs that thromboxane-dependent platelet aggregation and can worsen all the bleeding problems that we're talking about. And I'm just going to do a quick example of a consult. I just wrote a fake one out of like what I would write out. Again, anytime I do a consult to a provider, I physically, on my practice letterhead, I write out almost a paragraph and I send it to them, as opposed to just please clear for surgery, right? Take time because it is a poop in, poop out system. So example here, dear Dr. Hematologist, Mr. Bleedy Gums is a 50-year-old male with a past medical history positive for atrial fibrillation with a history of several clots, for which he is anticoagulated on rivaroxaban. He needs 2 teeth extraction, which I plan on performing under local anesthesia, and I plan on using adjunctive hemostatic agents. I believe in shared communication and decision-making. From my understanding of the CHEST 22 guidelines and the evidence, I would be comfortable continuing the rivaroxaban around and through surgery. As from my point of view, it's very low risk And with the adjunctive agents, I can manage the bleeding, which typically only loses 5 to 10 milliliters during surgery. Please let me know what you think. If I'm missing anything about understanding his risk stratification and considerations, if you would prefer it to be held, and if so, please communicate that to both myself and the patient. I deeply appreciate your time and help in Mr. Bleedy Gum's care. And I think part of that to highlight is I am trying to not only say, hey, I care about your side of it as well and understand these things, but here's, I usually lose about this much blood. I can manage it with these agents. I'm trying to give them insight into our world because remember, they just think, they have 44 hours of med school education on teeth. So understanding what a typical extraction or set looks like, they have no frame of reference. So I try to give that to them.
That's so good. That's incredible narrative and way to frame it for them so they can have a good idea of how to consult you. I mean, one question I was going to ask was, do you always send a med consult, or are there times where you'll feel comfortable just saying, hey, hold it and we're good, or don't hold it?
Yeah, that's a good question. That's actually a really good point. So generally, actually for this one, like this guy, I may have considered not. So if it falls really in that like 1 to 2 teeth category and their indication for anticoagulation is not like they're not like super sick, they don't have renal issues, I may just, especially if it's a more urgent consideration, personally, I may just proceed with it. Now, I think I would advise everybody to, from a legal standpoint, always consult, but if it falls under that very clear, we can continue for a lot of these, I have done that certainly, and I personally feel comfortable with that. If that same patient, though, is kind of a train wreck or sicker, ASA 3.5 to 4, maybe before I rock and roll, especially for something elective, I may get that consult. But generally, once we start touching intermediate or high risk bleeding surgeries, like again, roughly 3+ teeth, certainly full mouth extractions, bunch of implants, trauma surgery, I'm going to get that consult. And I have done it all the ways, right? I have done full mouth extractions, maintaining people on DOACs in a hospital and helping out with patients like that, and like transplant patients and everything, and all sorts of things. And you know what? Most of the time, it's fine. Most of the time, using some hemostatic agents, good suturing, stuff we talked about last time, TXA malference in particular. But you have to be ready for that. Generally 1 to 2, sometimes up to 5% of that time, they're going to have to go back to the ER just oozing and kind of bleeding from the mouth. So it's kind of a game of risk involved, but talking with your patient and making sure they understand if this happens, do this, right? Bite on the tea bags, use the mouth rinse. If all that fails, go to the ER. I'll come, and then see you there if I have to. Having the plan in place up front to deal with those, 1 or 2 in 100 cases will probably make your patients feel better and, make us do better care for our patients.
Did you just make these consults up from scratch, or did you find good templates like this, or did you just plug these into ChatGPT?
No, actually I don't. I just hand jam them. It takes me like 5 minutes.
Nice.
Maybe a little easier for me because I know most of the stuff, I'm familiar with having dug into it enough where I can just, okay, chest 22 guidelines, like, this is roughly it. But
yeah, okay.
Idea, but yeah, it's the extra 10 to 15 minutes it takes at the end of the day to send a couple consults, I think will enhance patient care, right? As opposed to they get the form fax that says, please clear for surgery.
Right, for sure.
I just think, we owe it to our patients and, each other as specialists to try to do that better job. And just a couple final thoughts here, Grant. Clinical judgment is the most important thing, right? There's no scoring system or calculator to determine the risks for what we can do, what we're comfortable with as surgeons, and all of that stuff. Make the plan and talk with the person or the team managing the anticoagulation. If you're not comfortable, just lean on them. I don't know what to do here. I'll leave it up to you. Describe your surgery a little bit, right? Try to help them understand. And, discuss it with the patient. You can have the frank discussion, especially in the intermediate phase. Hey, because a downside to stopping the anticoagulation is you may have another stroke, for example. The downside of continuing it is that you may have a bleeding event that have to go to the emergency room or require more therapy, and document that. Document it. It's okay to discuss that with the patient. This is kind of variable. It's a gray area. Evidence isn't great. I'm going to talk to your blood doctor and try to figure this out. That's extremely protective, I think, medical legally. And honestly, it's also the right thing to do.
Oh, yeah. Such a good point. I mean, because we have these conversations all the time with our patients. At least I do. I'm pretty sure most of us do, about, hey, here's the pluses and minuses, and it's kind of more of a let's fill this out together as a doctor and patient sometimes, not always, but but then documenting that to back something up if they do have a big bleeding event afterward is definitely protective of yourself.
How often you see it? Like, is it like once every other day you see a patient anticoagulated, or once a week kind of thing, or just as like a? I'm curious, is it a rough ballpark?
Yeah, I would say it's more in the realm of once every other day, like several times a week. Yeah.
Have you ever had any issues where you've because as we talked about last time, like even stopping these around surgery, in my experience, these patients tend to be a little bit more bleeding and more likely to have to go back to the ER afterward. Have you had any of those kind of events where like they come back in the office kind of oozing or big issues?
Yes.
Yeah.
Yeah, not big issues, but yeah, occasionally it's probably in that realm of the 1 to 5%, out of 100, maybe you'll get one or two people who are still kind of bleeding, and sometimes they're going to, coming back to the office the next day or that later in the night, and you're doing extra things to try to help with the clotting. The times where I've had to send them to get like, some type of infusion at the hospital to reverse things is like once every few years. I mean, that's very rare.
Yeah. Nice. Yeah, it's one of those themes that I have seen pretty consistently where it's that somewhere in the 1 to 2 to 1 to 5% range of like problems afterward.
I agree.
Well, awesome. Hopefully that helps folks out there at least. I think it's so important to understand how these things work because it informs all the decision making, and because it's all gray, it's I think important to understand. I was talking to somebody recently too, a number of friends, and they say things like, "Nah, I just tell everybody to stop, like have their hematologist stop it, or like I don't care at all. I let the hematologist do it." And I'm like, well, we probably should understand a little bit more about it, right, guys?
Sure. Yeah, no, this has been really helpful for me. And I think probably for a lot of us brushing up, but I just try to be curious too when they're on, you're going through their med history, and when they're on Xarelto, what's it for? And that's interesting. And I kind of take a log in my head. Oh, that's interesting. Most of the patients that are on Pradaxa usually kind of have this issue and for this and that. But trying to take an interest and paying attention to some of the details here can be helpful.
Yeah. Check it out, team. The Chest 22 guidelines on perioperative anticoagulation management. It's a wonderful paper with some good evidence, and you'll see everything I talked about, the murky qualifiers and the fact that nobody really understands what we do.
And we'll put a link to that article in our show notes, and I'll put your contact info as well, just in case people want to reach out. But I love your passion for hematology. The fact that we're doing multiple podcasts on this is just thrilling.
Hey, that's me and you, Grant, just grinding on the content engines, trying to boost our residents up, the trainees, and
That's right.
knowledge into people's minds. Yep.
It's good stuff. All right. Well, thank you so much. I appreciate your time, and especially all the time you've put in before this podcast to get this incredibly high octane information to us is awesome.
My pleasure, Grant. Thank you, my friend, and team. We'll catch you at the next one.
Good. Talk to you later. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.